If amlodipine is sitting in your pill organizer right now, there are 5 specific things you need to know. Not 5 rare complications. Not 5 medical emergencies. Just 5 ordinary situations that millions of people encounter every week without giving them a second thought. And at least one of them is probably something you've done recently, maybe even today. Most people never hear about these interactions because a typical prescription appointment focuses on the essentials, and there is rarely enough time to cover everything that matters. The conversation usually covers the dose, the reason you're taking it, and perhaps one common side effect. Then it moves on because there are always other concerns to discuss. What often never gets mentioned is what happens when amlodipine meets a certain fruit. What happens after several missed doses? What happens during a long period of standing still? What happens when a common pain reliever enters the picture? Or what happens when someone quietly decides at home to stop taking it altogether? Those situations may sound unrelated, but they matter more than most people realize. Each of these situations seems completely disconnected from a blood pressure medication. Yet together, they account for a surprising number of amlodipine-related complications I see in adults over the age of 60. Amlodipine is one of the most commonly prescribed blood pressure medications in the world. It belongs to a class of drugs known as calcium channel blockers, which relax the smooth muscle inside arterial walls and reduce the resistance the heart must pump against. It's effective, extensively studied, and generally very well tolerated. But the same mechanism that makes amlodipine effective also creates predictable interactions with certain foods, medications, behaviors, and decisions that are rarely discussed when the prescription is first written. Research examining amlodipine-related adverse events has repeatedly shown that many complications are not caused by the medication behaving unpredictably. Instead, they occur because one of a small number of factors changes how the medication behaves in a particular person on a particular day, often without that person realizing it. My name is Dr. Sarah Mitchell. Before we continue, do not stop, reduce, increase, or change your amlodipine dose based on anything discussed in this video without first speaking with the physician who prescribed it. Everything we're discussing today is information to bring up at your next appointment, not a decision to make on your own. The goal is to help you recognize potential problems and understand why they happen, not to encourage changes to your treatment plan without professional guidance. Over the next few minutes, I'm going to walk you through 5 specific things to avoid, explain the science behind each one, and most importantly, tell you what to do instead. Stay with me through all 5 because the 5th item is directly connected to the first 4. Once you understand it, the way you think about everything else in this video may change completely. Before we begin, I want to tell you about a patient I'll call Reginald, because his story ties together several of the issues we're about to discuss. Reginald was 75 years old, a retired postal worker, and a man who valued routine. He had been taking amlodipine for just over a year. Then, over a period of roughly 10 days, several things happened that seemed completely unrelated at the time. We'll come back to him throughout this video because by the time he came to see me, 3 of the 5 situations I'm about to describe had all occurred within the same short window. Together, they produced a blood pressure reading that frightened him and eventually led to a hospital visit that could have been avoided. Before I go through the list, I want you to notice something. None of these situations sounds dramatic. A piece of fruit, a missed dose, standing in a long line, taking a tablet for joint pain, making a quiet decision at home. That's exactly why they matter. People naturally become cautious around things that feel dangerous. These don't. And that's precisely why they catch so many people by surprise. Give me a few minutes, and by the end of this video you'll understand why these ordinary situations deserve much more attention than they typically receive. Thing number 1. Grapefruit and grapefruit juice. Amlodipine is metabolized in the liver by an enzyme known as CYP3A4. Grapefruit and grapefruit juice contain compounds called furanocoumarins that irreversibly inhibit this enzyme. When the enzyme responsible for breaking down amlodipine is blocked, the medication accumulates in the bloodstream at concentrations significantly higher than the prescribed dose was intended to produce. The result isn't a different medication, it's effectively more exposure to the same medication than your physician planned. Research has shown that a single glass of grapefruit juice can increase amlodipine blood levels by anywhere from 30 to 90%, depending on individual CYP3A4 activity and the amount consumed. Think of CYP3A4 as the exit door through which amlodipine leaves the body. Grapefruit locks that door. The medication that should be leaving remains in circulation instead, gradually building to levels the original prescription was never designed to create. It's a simple interaction, but one with consequences that many people never recognize. The symptoms of this accumulation often look exactly like the side effects listed on the medication label: dizziness, flushing, palpitations, headaches, and the ankle swelling we'll discuss later. Many patients experiencing these symptoms are told they may simply be sensitive to amlodipine, when the actual cause is a food interaction creating an unintended increase in drug levels. This interaction applies not only to grapefruit juice, but also to whole grapefruit and any beverage that lists grapefruit as an ingredient. Seville oranges carry a similar risk because they contain many of the same compounds. Sweet oranges, lemons, and limes do not contain significant amounts of furanocoumarins and are generally considered safe. So what should you do instead? If you're taking amlodipine and consuming grapefruit in any form, stop and mention it to your pharmacist or physician. The same CYP3A4 interaction affects many statins and several other commonly prescribed medications, making a complete medication review worthwhile sooner rather than later. That's the interaction most people have never heard explained. The second item on this list is one that your instincts may tell you is the responsible choice. But in this specific situation, those instincts can be misleading. The mechanism behind thing number 2 explains why some of the highest blood pressure readings I see occur not while someone is taking their medication inconsistently, but in the days immediately after they decide to stop taking it. And that's where a surprising number of avoidable problems begin. Thing number 2. Stopping amlodipine abruptly. Amlodipine works by relaxing the smooth muscle within arterial walls, helping arteries remain more dilated than they would naturally be. After months of consistent use, the arterial smooth muscle adapts to that ongoing state of dilation. When amlodipine is suddenly stopped, whether because of a side effect, a desire to manage blood pressure without medication, or simply because a prescription wasn't refilled on time, the arteries do not immediately return to their previous baseline state. Instead, some patients experience rebound vasoconstriction. In simple terms, the arteries temporarily become narrower than they were before treatment began, producing blood pressure readings that may exceed the person's original baseline. Think of arterial smooth muscle like a spring that has been held in a stretched position for months. When the tension is released suddenly, the spring doesn't always return smoothly to where it started. It can overshoot, contracting more tightly than its original resting position before eventually stabilizing. The blood pressure surge associated with abrupt amlodipine discontinuation can occur within 24 to 48 hours of missed doses. In adults with underlying cardiovascular disease, that temporary surge carries a genuine increase in the risk of stroke and other cardiac events during the rebound period. If amlodipine needs to be stopped for any reason because of side effects, a medication change, or any other concern, that decision should always involve your prescribing physician rather than becoming an experiment you conduct on your own. Your doctor can determine whether a gradual taper, a replacement medication, or another approach is the safest option for your situation. Never simply stop taking the medication and wait to see what happens, because the period when you're waiting for an answer is often the exact period when rebound blood pressure elevation is most likely to occur. And unfortunately, that's when many preventable complications happen, not because the medication failed, but because it was removed too suddenly from a system that had already adapted to its presence. Thing number 3. Standing motionless for long periods. This is the one most people never connect to their medication. Amlodipine's vasodilating effect is not evenly distributed throughout the circulation. It tends to relax the small arteries feeding the capillary beds in the lower legs more than it relaxes the veins responsible for carrying blood back toward the heart. That difference becomes important during situations that seem completely harmless, standing in a checkout line, attending a church service, waiting in a long queue, or spending time gardening without moving much. All of those situations rely heavily on something called the calf muscle pump. Every time you walk, the muscles in your calves contract and help push blood upward from your legs back toward your heart. When you stand still, that pump is largely inactive. Combine that with amlodipine's tendency to widen small arteries, and blood can pool in the lower limbs more easily than it would in someone who isn't taking the medication. It's a simple physiological effect, but one that many people never realize is happening. The consequences can appear in two different ways. The first is dependent edema, the ankle and foot swelling that often becomes noticeably worse after prolonged standing. This is different from the baseline swelling some people experience from amlodipine alone. The second issue may be even more important. Certain adults, especially those who are dehydrated, taking additional blood pressure medications, or prone to orthostatic blood pressure changes, may experience a temporary drop in blood pressure when they begin moving after standing still for a prolonged period. The result can be lightheadedness, dizziness, a sense of instability, or in some cases even fainting. Think of your circulation during prolonged standing on amlodipine like a dam where the incoming channels have been widened while the outgoing pump has been temporarily shut down. Fluid gradually accumulates behind the dam. Then, when movement suddenly resumes and the pump switches back on, blood redistributes quickly enough to cause a brief reduction in pressure reaching the brain. That short-lived shift is often what people experience as sudden dizziness. So what should you do instead? If you know you'll be standing for an extended period, whether at a service, in a long line, or while working in the yard, shift your weight regularly. Flex your calf muscles. Take a few steps every few minutes if possible. These simple movements reactivate the calf muscle pump and help prevent excessive blood pooling in the legs. And if you're about to start walking after standing still for a long time, pause briefly and steady yourself before moving. That short pause allows your circulation time to adjust. Have you ever felt lightheaded after standing in one place for a long time and then suddenly starting to walk? Many people have, and most never connect it to their medication. But thing number 4 works through an entirely different mechanism. Not an enzyme interaction. Not a rebound effect. Not a circulation problem. This one involves a direct chemical interference with the very process amlodipine relies on to lower blood pressure, and chances are, it's already sitting somewhere in your medicine cabinet. Thing number 4. Regular NSAID use. Medications such as ibuprofen, naproxen, and similar anti-inflammatory pain relievers are commonly taken for arthritis, joint pain, back pain, or everyday aches and pains. Unlike the interactions often discussed with ACE inhibitors and ARBs, NSAIDs affect amlodipine through a different pathway. They work by inhibiting the production of prostaglandins, chemical messengers that perform several important functions throughout the body, including supporting healthy blood flow and helping the kidneys regulate sodium balance. When prostaglandin production is suppressed by regular NSAID use, the kidneys tend to retain more sodium and water than they otherwise would. That directly opposes part of the blood pressure lowering effect amlodipine is trying to achieve. At the same time, prostaglandins contribute to vasodilation in certain blood vessels. Reducing their activity can partially blunt the arterial relaxation that amlodipine depends on. The medication is still working, but some of its intended effects are being quietly pushed in the opposite direction. Research has consistently shown that regular NSAID use can reduce the effectiveness of many blood pressure medications. Calcium channel blockers like amlodipine are among those affected, although typically to a lesser degree than ACE inhibitors or ARBs. The practical consequence is easy to overlook. Someone whose blood pressure has been stable for months begins taking ibuprofen regularly for a painful knee or chronic back pain. Several weeks later, their readings begin creeping upward. Yet they never suspect the over-the-counter medication could be contributing to the change. Think of amlodipine's effect like water flowing through a widened pipe. Regular NSAID use is like partially closing a valve farther downstream. The pipe is still wider than before, but overall flow is being restricted by something the original widening was never designed to overcome. That's why blood pressure control may gradually worsen, even though the prescription medication itself hasn't changed. The interaction often develops slowly enough that people miss the connection entirely. What should you do instead? If you need regular pain relief while taking amlodipine, acetaminophen is often considered the preferred first-line option because it does not create the same interaction. If NSAIDs are genuinely necessary for a chronic condition such as osteoarthritis, that should be a conversation with your physician rather than a decision made independently in the pain relief aisle. Topical NSAID gels and creams applied directly to a painful joint result in much lower systemic absorption than oral tablets and may be a safer alternative worth discussing. Now we come to thing number 5. This final issue connects directly back to thing number 2. It is also the single most common reason I see patients stop taking amlodipine without first speaking to their doctor. And ironically, the symptom that leads them to quit the medication is often a symptom that can be managed successfully once the real cause is properly understood.